Thank God.
Ai ta yi bayan zama ita da maza ma suke shiga daga jerin wato daki kuma wannan bayan zama. Ko labari ne.
Ni na so ba ta iya zuwa ga nan a cikin gidan. Ba iya ba. Can ma kin ga ko
ban ka abin da zai samu ni in ci gaba da yi mata imani ba bai shi da
Titi to ai ba sani ba kai a siti mu kawai na fara dive da Ismail. Hankali irin eh Lau da Ismail fito.
Muito. Bí kíní speaker mi ló ti gbé.
Wallahi billahi la ilaha illa wata ma da take ce. Da
Yana da mutum shi na koyi.
amma so da kuma na shari wuce ko shi na radima kuma abi sai ne shi da ji ga wata siyasa ba kuma abin da suke ci mara kyau ba wannan kazan da ake ci shi ba sa yi ci kashi suke abincin su amma da ya ci ba haka da ke shi ma ba ya fasa wani kwanke shi ne ya san girma ka wallahi al'azim na rantsi da kudurar Allah wallahi al'azim dan haka shi ya wallahi ba ran bagur da rubiya wallahi ce suke kawo
Shiga cikin.
Fauziya Shaibu, please mute your mic. Fauziya Shaibu, mute your mic.
Okay, kin ji what kike faɗa ne?
Hello, Fatima Ahmad, please kindly call Fauziya private.
Hello, good evening, everyone. Hello, good evening, everyone.
Good evening, ma'am.
Hello, good evening.
Good evening, ma'am.
Good evening,
Good
ma'am.
evening, ma'am.
Good
I was
evening.
actually waiting for us to call to start the meeting. Are we supposed to start this meeting with the teaching first? Is there any moderator for the meeting? Do I have any moderator for this meeting? Can we hear me?
Yes, we can.
Yes, we can.
Yes, we can hear you, ma.
Okay, is there any moderator? We just go straight to the teaching tonight.
Actually,
Do we
there's
go
supposed
straight
to be a
to the
moderator.
meeting, or we have a moderator? Do we have
Yeah,
anything
there's
to
supposed to
do
be a
before the
moderator,
meeting
but
starts,
I
or
don't
we go
think she's
straight
here
into the
yet.
teaching?
I
The
think Miss
moderator is not here
Victoria,
yet. It's supposed to be Chidera, so she's not here yet. I don't know
Okay.
what.
Victoria is
Do we
my
wait
host.
for her?
Yeah.
Do we wait for her, or we go ahead with the meeting?
I'll suggest we go ahead.
Ma, please go ahead with it.
Okay.
Please go ahead, ma'am.
All right. Okay. So Okay, can we see the screen? Can we see the screen? Hello, everyone. Can we see the screen?
Yes, ma, we can see your screen, ma. Can go ahead.
Okay, thank you. Good evening, everyone, once again. We'll be talking on WHO rehabilitation domains. And looking at that domain, we'll be looking at the domains, we'll be looking at how we can effectively use the domain in the assessment and management of pediatric conditions. Let me start by saying the Rehabilitation 2030 is a World Health Organization concept. And the initiative behind this was that the World Health Organization wants to bring the whole world or world leaders into the acknowledgement that there is need in achieving universal health coverage. There is need for all governments to look into rehabilitation. One of the main reasons why health services is still not accessible to all people is because you look at the various categories in health care delivery. Primary health care, which is where you have a lot of people at the rural level, you find out that they are not able to access the basic health care they need. For example, at the primary health level, let's use our country as an example. You have the nurse and probably a primary health doctor there. Now, when a patient is brought in from the village who has just sustained a cerebrovascular accident, the patient is brought in, the patient's blood pressure probably is checked, and then patient is stabilized by the nurse and the doctor. And after stabilizing the blood pressure, you discover that this patient has either an hemiparesis or an hemiplegia on the left side, on the right side. Now, this patient, after stabilizing the blood pressure, is probably given some anti-hypertensive drugs and told to probably go to the nearest general hospital or go to the nearest tertiary hospital. So I don't know, for all of us on the platform now, I want you to imagine where your tertiary hospital is in your own locality, or where the nearest general hospital is in your own locality, and think of the farthest village. Now, for such a patient to start going to the nearest tertiary or secondary healthcare center, that is enough discouragement. Now, this patient, though the blood pressure is stabilized, but the patient is unable to go back home, has to be conveyed or carried home because there is paralysis or paresis of one side of the body. As a result, this patient cannot access rehabilitation, which is the basic thing. Because of inability to access, you have, at the end of the day, disability increasing in the society, and the problem of quality of life being affected is also there. So WHO actually came up with the Rehabilitation 2030 concept to be able to draw everyone's attention to the fact that rehabilitation is actually a key aspect of universal health coverage. Assessing health does not mean taking care of impairment alone. If impairments are taken care of, if impairment
Hello, ma, we can't hear you.
Can we hear me now?
Yes, ma, we can hear
Please,
you.
at any point, please, I will appreciate if I have a moderator on ground or somebody to be moderating this meeting. So at any point while talking, you can't hear me, please. I would love if I can be notified on time so that I don't keep talking, thinking I'm being heard, and probably nobody's hearing me. Please. Thank
Sorry,
you
ma'am.
so much.
Okay.
All right. So as I was saying, rehabilitation is a key aspect of assessing universal health coverage. Very, very important. So we go to our slides. Now, I started by telling us how Rehabilitation 2030 came in because part of number 3 of the SDG goals, which was set up, 2030 SDG goals, was good health and well-being, universal health coverage. Now, in achieving this, rehabilitation has actually been brought to a point where WHO has brought this to a point to show that an essential part of achieving universal health coverage is rehabilitation. And there is need for the whole world to know that rehabilitation worldwide needs to be improved upon. We're not just talking about assessing primary health service, but beyond assessing that basic health, what happens to that patient? Is the patient restored back to as near normal as possible? Can the patient resume work? Can the patient go back to what his lifestyle used to be? How much of function has been restored in that patient? So, as part of the WHO 2030 agenda, WHO is trying to provide a strong political commitment to public health, which states that public health involves promoting physical, mental, and social well-being and extending life expectancy for all. In order for one to achieve universal health coverage and to access quality health care, the focus must be to extend life expectancy for all. And this brings us to the role of rehabilitation in all of this. Rehabilitation is a set of interventions that is designed for the purpose of optimizing function and reducing disability in individuals with health conditions and ability to interact with their environment in spite of their health condition. Now, rehabilitation actually is what helps to improve independence. Rehabilitation is what will help a child, an adult, an aged person in geriatric to be as independent as possible. I stated an example of somebody with an impairment. I used that of a stroke patient. Even the man that just was involved in a road traffic accident with a compound fracture, after he's taken into theater and the fracture has been reduced, that patient cannot come down from the theater bed and begin to walk home. It needs one form of rehabilitation or the other to be independent, to be able to interact with his environment, to be able to interact with other people, to be able to move around, and to also be able to communicate. Now, communication in this form, I'm not just talking about speech, but communication in terms of relating with his environment. So that takes us to briefly the elements of rehabilitation: preventive rehabilitation, restorative rehabilitation, supportive rehabilitation, and palliative rehabilitation. So going to our topic proper, the Rehabilitation 2030 WHO domain. It's also called the WHO Package of Intervention in Rehabilitation, looking at the assessment using the domains to assess and effectively intervene in pediatric conditions. So for this class today, what are the objectives? We want to understand the assessment of pediatric condition using the WHO PIR. Like I defined it earlier, PIR is talking about the package of intervention in rehabilitation. Now, also, we want to be able to achieve the best plan we can acquire in effective intervention using the WHO PRL in all childhood conditions. Most of the time, pediatric conditions, especially the neurological ones, are termed CLC, that's chronic long-term conditions, childhood chronic long-term conditions. So how can we effectively use the WHO PRL to achieve, to plan effective intervention? We also want to be able to evaluate the multiple domains we have in every condition. How do we evaluate the domains, and how do we, despite the domains, prioritize intervention? We want to be able to apply this knowledge in the different specialty fields. And finally, we want to be able to apply the WHO PIR in clinical practice for effective management of pediatric conditions. Now, can I ask once again, am I being heard by everyone?
Yes, ma'am.
All right, thank you very much. Okay, so I can go ahead.
Yes,
all right.
Please.
Quickly, pediatric rehabilitation intervention starts from the moment a child is born. Some of us may be wondering why. Even if the child does not have any condition, even if the child has not been observed to have any disease, yes, because intervening in childhood conditions is not just because there's a disease that has been observed or there's an absence or presence of any disease. No. Childhood intervention actually is basically to monitor growth and development, which is very mandatory. For example, you have a little baby that has just been given birth to good APGAR score, no delay in cry, no jaundice at birth, no problem that you can actually lay a hold on. But intervening or assessing that child, you're not asking basically because there was a problem at birth or there's a presence of a disease. You are actually assessing that child to be able to monitor, was there a problem along the line in his growth or in our development? Once there's a problem in the growth and development, there is need for intervention. So that's why pediatric rehabilitation intervention starts from the moment the child is born. We have categories in pediatric rehabilitation actually, from 0 to 3 months at the neonate, or the first 28 days at the neonate. Then you have the first 18 months. First 18 months actually is what we call the sensory learning period, sensory motor learning period, wherein the child is beginning to observe parts of the body, observe the environment, to be able to learn in terms of achieving a function, performing a function, or understanding a function. And this takes place from the 4th month to the 18th month. That's a critical period of rapid sensory motor development. Now, what the child sees and understands in the environment is exactly what the brain will learn and the brain will replay as a function. I always give an example of the story, the movie Tarzan, to most of my caregivers. That's parents or caregivers or guardians of children with neuromotor development or neurodevelopmental delays. I always tell them the story of Tarzan. The story of Tarzan. Tarzan was born by his parents on a journey. They had a ship capsized, and then Tarzan, the parents died, and the little baby Tarzan, less than a month old, was actually left in the jungle. Now, this boy in the jungle grew in the jungle, and all he sees in his environment are monkeys jumping from one tree to the other. Apart from the monkeys, he sees other animals, but everybody in that jungle were walking on fours. Nobody was actually standing on 2 feet. They were all on fours. And Tarzan grew up even to a youthful age, walking on fours, because that is what everybody does. That is to tell you that in his critical period of rapid sensory motor development, all he sees and all the brain could interpret in information processing was everybody's walking on 4. Until when Tarzan suddenly, at a youthful age, saw someone come into the jungle standing on two, and the person kind of looked like him. The person has 5 fingers like him. And he started wondering. Then a moment of relearning started again. So quickly, we should understand that those first 18 months are critical period for learning. All right. So when we look at, in terms of intervention for pediatric cases, you are considering your method and means of intervention. But in considering your method and means of intervention, you must understand that this method and means of intervention varies from one age group to the other. For example, the baby you are treating who is 3 months old, and you keep managing, by the time that baby is 18 months, your pattern, your means and method of intervention must change to correlate with that present chronological age. Now, not just the chronological age, but also correspond with the physiological age. What has this child achieved? What should his age chronologically should be doing? So the means of intervention varies from infancy throughout childhood years to teenage years. And presently, we have the Gillick's principle that talks about the fact that a young adult of 16 years has every right to choose his manner or pattern of treatment as long as he can maturely understand what that treatment involves. So under the Gillick's principle, you find out that young adults are now also being put under pediatric or what I'll call childhood intervention conditions from 18 years to 25 years. So don't be surprised sometimes in your clinics, pediatric clinics, when they tell you that there's a 17-year-old that is being admitted into your clinic. It's actually permitted. And then that child has every right maturely to choose a treatment or to deny or to refuse a treatment, which is where also the place of consent comes in. You must seek their consent, not assuming that they are a child or is a child or she's a child. Now, in pediatric rehabilitation, it's a little bit complex. Now, what's the reason why? The reason why pediatric rehabilitation is complex is because most pathologic cases in pediatrics are multiple domains. When I say multiple domains, that means there is no single body system affected. You have so many systems affected at the same time. Most of the time, apart from the physical function impairment, you have cognitive affectation, you have emotional problems, you have communication skill disorders, you have speech affectation, and so many things are interwoven. So in pediatric rehabilitation, you have a lot of domains you have to attend to. Unlike in the adult rehabilitation, when an adult suffers a stroke, yes, other domains may be involved, but I can tell you that adult can easily learn to retrain himself and start using his left hand to perform his function. Why? Because the right hand has decided, as for now, is paretic. But for the little child, he has not learned to be able to do that. So you have to deal with so many domains at the same time. So from the day one of that child coming to clinic, you are having so many other specialties involved. The same child that you're treating because he has physical, motor function and motor delays, that same child, you have to make that child to also see an ENT doctor because there is speech problem, there is a speech pathology. You have to make that child see the ophthalmologist because the child can't focus or follow object. You have to make that child see the orthopedic surgeon because the child has probably a hip dysplasia, all of that. So there are multiple domains. That's why it's quite kind of complex. But apart from that, like I said earlier, most neurological conditions in pediatrics are termed chronic childhood long-term conditions. And these conditions, they always require an assessment, a reassessment every time, and of course, application of appropriate interventions. Can I pause here by asking, can we all see this slide? Please,
Yes,
can
ma.
we unmute? Can I hear somebody? Can we see this slide?
Yes, ma, we can. Can see
Okay.
it, ma.
All right, thank you very much. Now, this slide is showing us the WHO rehabilitation domains. These are the domains that have been established by World Health Organization as the domains for intervention in any case and in any condition. If you look at, we have domains A to W. Under these domains, you have domains for mental and cognitive function. You have intervention for emotional function, vision, speech, hearing, dysphagia. Dysphagia dysphagia is not the same thing with speech, though both of them can be intertwined, but it is possible that a child may not have the ability to speak, or because there's a dysphagia problem, swallowing issues. So they are all connected, but at the same time, there are domains that need to be managed. Intervention for nutrition, of course. When you have a child that is malnourished, how can malnourished child be affected by other domains? When a child is malnourished, what happens? That same child can have motor function problem, can have a mobility problem. So they are all intertwined in many ways. We have intervention for bowel and bladder management, intervention for sexual functions and intimate relationship, which may not really apply for pediatrics. Yes, but it's a domain that WHO believes should be looked at. Intervention for respiratory functions, for skin care, cardiovascular and hematological conditions, for motor function and mobility, interventions for fall prevention, for exercise and fitness, and to the last one, interventions for lifestyle modification. All right, moving on to assessment in pediatric conditions. According to WHO Rehabilitation 2030 rule, assessment is intervention. I'll try to explain what that means. The moment you start assessing a patient, you're already intervening. That is what it means. The moment you start assessing, because in the process of assessment, you are discovering one impairment or one medical ailment or the other. And once you discover an impairment, instantly you plan an intervention. Either you're applying intervention yourself or you're referring, whichever way it is a form of intervention. So assessment is actually the start of intervention. Now, intervention in rehabilitation, according to WHO, works with a rehabilitation domain. That means you don't just intervene arbitrarily. You are intervening according to a domain, which means you have observed. I'll take you back to the rehabilitation domain. You have observed in a child that this child cannot communicate. This child is having speech, language, and communication issues. So that is a domain. Now you, as a rehabilitation therapist, let me give an example. As a physiotherapist, your major role, you want to improve motor function, movement, and mobility. So what do you have to do when you notice a child when you're assessing has speech, language, and communication problems? How do you intervene? You intervene by referring to the right specialty or specialist who will be able to attend to it, knowing surely well that as you intervene in that area by referring, the patient is able to have total rehabilitation. So you're not just concerned with your own motor function, movement patterns, and mobility, but you're also intervening in other areas. Or you understand that, okay, this is a cerebral palsy patient. I'm trying to improve postural control, motor control, but this child is having vision impairment. So what do? You understand that if the child's vision is good, vision is one way by which you can also, is a technique you can use in applying or administering your intervention or your treatment technique as a physiotherapist. So now this child has vision impairment. What do? How do you intervene? You have discovered this during your assessment. You refer to the appropriate specialty. You refer to the ophthalmologist so that the ophthalmologist can attend to the vision impairment, because you know when the vision is taken care of, it will improve also your own intervention as a physiotherapist. I don't know if we have speech pathologists in this class. We have other colleagues in this class. So you refer when you should refer when it is not within your own specialty field. So assessment is intervention, and it involves two main rules: approach and purpose. When you're assessing, what is your purpose? It is to restore function. When you're assessing, what is the approach for you applying your intervention? Now, to you who wants to probably treat, you have discovered your own area of intervention. To you, what do? Your approach is, after assessing and I've discovered this is where there is an impairment for me to attend to, your approach is you look at what is the means by which I can restore this function, and what is the method of treatment I'm going to apply to restore, to restore function. Are we together? So in doing your assessment, you have your purpose, what's the purpose, and what is the approach. So let's move on quickly. We'll go to the next slide. In your assessment, starting, what do we do when we want to assess? We start by inquiring. You inquire from the caregiver, from the guardian, from the parents. What happened? What is wrong? What's your pregnancy period like? Was it a premature baby? You're making inquiries because you want to gather information. Now, after making inquiries, you're also observing, like you have in the picture. You have a baby with Amelia and missing limb, loss of one limb or the other. So you're asking and making inquiries from the guardian. What is the history of birth? How was the pregnancy period? Any problem, any issues? You get information from there. At the same time, you're observing the child, and you're now making analysis from your observation. And of course, you're documenting what you have analyzed. Then you move on from making inquiries and observation. You move on to more detailed assessment, where you do an objective analysis. From your objective analysis, you evaluate. And then after evaluation, you apply based on evidence. You apply based on evidence. Okay, I'll give you a simple example. There's a little baby you're assessing from all the history the mother's given, and then from your evaluation, you are noticing that the child is this is not a 6-month-old child. This is actually a 10-month-old child brought to your clinic with no neck control, cannot roll, and the child keeps gazing on one side, in one direction, and you try to turn the head the other direction, and you notice that the hand facing the occiput extends. That already gives you an idea. Oh, this child has ATNR, that is a primitive reflex that is persistent. So that is already one evidence you have based on your evaluation that, okay, apart from the history you've gathered, primitive reflexes are still persistent in this child. Primitive reflexes that should have faded away at 6 months. All right, this is already giving an idea of issue of either a palsy, a cerebral palsy, a delayed developmental milestone, or neurodevelopmental condition. So you analyze, you compare your evaluation with evidence to be able to, at the end of the day, bring you to a defined plan of intervention. A defined plan of intervention. What does that mean? You are now able to have an impression, okay, this is the issue, this is the diagnosis I'm bringing out for this child, and this then is my plan of intervention. So, assessment and classification in pediatrics differs according to age. Yes, and all domain and all comorbidities must be evaluated. The details of the assessment should be around the activities and functioning of the child. That's according to ICF, and it must be linked to the goals and age of the child. You are not now drawing assessment of a 3-month-old baby brought to you with inability to, a 5-month-old baby brought to you with convulsive episode and inability to hold the neck. You are not comparing that particular assessment or linking your intervention for that child with that of a 12-month-old, a 1-year-old child who's also having what? Who's also having no neck control and convulsive seizure disorders. So you must link your assessment and intervention plan to the goals and the age of that child. That will help revolve around the international classification of function, wherein you are achieving function or you are planning function according to the age of the child. In assessment, briefly, let me just point this out. Assessment is not static. It is never static. Why? As you are managing, the child is changing with age. The child is learning new things. The brain is interpreting information as the child is growing. So obviously your assessment must be continuous. So assessment is dynamic. It is not static. And that is the only way you can be able to achieve a successful rehabilitation. And that takes me to our assessment medium. Formerly, we used to use the SOAP format. What is wrong with the SOAP format? There is really nothing wrong, but it's just that the SOAP format is not so well applicable anymore. It is the SOAPIA format that is applicable now. Why? The SOAP format points you to an impairment. After the impairment is taken care of, you don't go back to begin to examine what is the level of function you achieve, and can you still achieve more function? We all know SOAP, subjective, objective, analysis, and plan. And once that plan, the patient comes in, a little boy with pain, had an ankle sprain, okay, and he started managing, you take care of the pain, and the boy says pain has gone down. Very good. Then you discharge. That's SOAP format. But the SOAPIA format is a systems format wherein you are not only taking care of the pain, but you're also observing after the pain has subsided, you notice that the child is still dragging the feet, probably dragging the feet in eversion, still trying to clear his gait, still having difficulty with good knee flexion to be able to clear his gait. That takes you to assessing other systems. Now, what makes the SOAPIA format better is because it embraces the ICF. So you're not only taking care of the impairment, but you're now incorporating the child's participation with the environment, with his environment. This child, is he in play class? Is he in grade 1, grade 2? What are the activities in grade 1, grade 2? Do they have twice a week physical education period wherein they have to go on the field and run around? So it helps you to be able to incorporate the child's environmental factor, his participation, even in his own personal factor, in the house where they live. Is he an upstairs? How is this child able to climb upstairs, to his room? So that is very important. So we use the SOAPIA format. Now, in your assessment, what do we assess? Even with the SOAPIA format, you assess all domains. All domains. You assess all domains. You assess comorbidities. Are there comorbidities? This child that just had a sprain, what is the genotype of this child? This child is an SS, that is anemic, sickle cell anemic child, is there a possibility that this child may have more probability for falls? Do you understand? So you assess all other comorbidities and plan your treatment for the child to be able, for you to take care of these other comorbidities. You assess interactions between systems. You assess interactions between systems. Okay, you are managing a Duchenne's muscular dystrophic child. You're trying to take care of, because child is already having this this foot deformity they normally come down with, trying to walk on toes, and the calf just increasing in size. You think is atrophying, is not, it's just full of fat. So you're trying to make a corrective shoe for this child, but at the same time, you understand that this is a condition that can also affect the respiratory system. So you're not only taking care in terms of the function, the mobility and movement, you are also engaging this child in strengthening of the respiratory muscles, because you know there's a tendency for it. And you understand also, in terms of interaction, you understand also the role of the neuromuscular system with the musculoskeletal system. So you assess interactions. Is there an interaction between this musculoskeletal condition this child has come down with and the neuromuscular system? You also assess function. You also assess adaptation. Now, I'll use this particular point. I'll use an example of a patient I have, a spinal muscular atrophic patient, a young girl. This child, because of the case we're talking about, consistent atrophy and hypotonia of the muscles, so we are constantly managing, trying to maintain muscle property and teach functional task-oriented exercises and improve active functioning. Now, this child, at the age of, she's presently, I think she's presently 6 years now. At the age of 6, this child, because of this condition, cannot actually flex the shoulder, elevate the shoulder to pick something above her head if you tell her to do that. But over the years, this child has learned to adapt. What is the adaptation? When you tell her to pick something above her head, what she does, she flexes the elbow, adducts the shoulder, and then bring her fingers to her hair. She brings the fingers to the hair and begins to climb her head with the fingers. She climbs her head with the fingers till she's able to use that to raise her hand above her head and pick whatever you're giving her. That is a form of adaptation. Now, for this child, considering and understanding her condition, you don't begin to tell this child, no, don't do that again, don't do that again. And you're telling the child to wait until whenever she can raise the hand normally. No, 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 no. You need to assess her function and her adaptations and see how you can improve on the function and probably progress from that adaptation, or you help her achieve function through her adaptations. You also assess medications. There are medications that your patients are taking, and because of those medications, it's difficult for the child to participate in treatment. Those of us that are neuropediatrics, you understand what I mean. When your patient comes to the clinic and you want to attend to them and the baby is sleeping throughout the treatment session, and because you are even trying to make the baby participate, the baby is angry because you are disturbing her sleep, and you are not considering what could be making this baby sleepy throughout treatment. You consider the medications, you assess the medications. Most of their anti-convulsive drugs, most of them makes them very drowsy, they are sedative. So you want to engage the caregivers. All right, what time do you give these drugs? This is an 8-hourly drug. So you advise, that is part of your assessment, so that the child can be awake and alert during treatment to be able to participate. Remember, you are engaging the child. You are not performing passive movements, and then you stretch because the child is spastic, and then you tell the mother, continue to stretch and go home. No. You assess the key issues. What are key issues? Key issues are those underlying conditions that you must put into consideration when you are planning your intervention. If you ignore those key issues, you know that they will ultimately affect your own treatment or intervention. And you assess baseline factors. Baseline factors, you have a Down's baby, a Down syndrome baby you're trying to train, and these Down's baby already have some aventricular defects. You don't want to ignore that. Baseline factors are those factors that if you don't take into consideration, they will end up affecting your intervention. So you take into consideration this baby has been referred to you for management while they are preparing to go for surgery. So in the meantime, they want you to start doing a pre-op physiotherapy for this child. So you want to grade your exercise routine. You want, like you're trying to manage a cardiac patient, you want to grade your exercise routine. You don't want to deny or ignore the fact that there's a baseline factor that must be considered. So quickly, intervention for rehabilitation domains. You don't treat the organ. Rather, what you do, every form of intervention you apply is to restore function to that organ. You want to restore function in the organ, number one. So you're not treating the organ. No, not at all. Your choice of intervention should be targeted at restoring function. Remember what we said earlier. There are two main aspects of assessment. What is it? Your approach and your purpose. So your choice of intervention must be targeted at restoring function or facilitating a specific function. Intervention, remember, works within a rehabilitation domain. And your means, your approach is your means and method of treatment. So let's quickly go to a little practical class in using this PIR, WHO PIR, for assessment and intervention in pediatric conditions. So now, a patient has just been brought to your clinic. An 8-year-old child was brought in by the mother, and the mother is complaining that this child had fever 5 days ago. She took him to the hospital, and in the hospital, a private clinic, the nurse gave him injection, intramuscular injection. And after the injection, the child was in pain and was withdrawing the limb and would not step on it. Well, of course, the nurse says, don't worry, he's just a child, it's the initial pain, just go home. After some time, after some hours, he will get over it. All right, you've gone home, the mother went home. 2 days after, the child is still not stepping. The child is withdrawing the leg. And you go back and the nurse said, okay, don't worry, just use hot water, press it, all of that and all of that. So somewhere along the line, this child has been brought to your clinic. In assessment, what is the rehabilitation domain you can see in this child? Number one, as a physiotherapist, I'm using a practical case of a physiotherapist who has this child brought into his or her clinic. So what is the domain? You look at all the rehabilitation domain. You can find the domain of pain in this child. You can bring out the domain of motor function and mobility. Could there be other domains? Yes, there could be, but let's look at this simple case first. We'll still touch another one. So when you have brought out the domain, what is your intervention target? Your intervention target is the area or that aspect. Remember we said you're not treating the organ. Your intervention is targeted towards what? Restoring function in that organ. So now, where is the pain? The pain is in the gluteus. It's a gluteal pain. So where is the intervention target? It is in the gluteus. So you have a gluteal pain. So when you're trying to take care or intervene in this pain, you know it is the gluteal muscle you will be looking at. Wherein, of course, we have the sciatic nerve that was irritated. lying underneath. So you are not treating the sciatic nerve. You are not trying to take care of the gluteus. You're trying to take care of the pain in the gluteus so that the gluteus will be fine. And this child will stop withdrawing the limb because of pain. That is the intervention target. Under the domain of motor function and mobility, what is the intervention target? The child is withdrawing the leg, so it's not weight bearing. So what you observe is this. There is no dorsiflexion, there is no knee flexion, there is weakness, there is gait and balance function. What is intervention target here? That particular lower limb. Is it the right or the left lower limb? That particular lower limb. So you're now looking at the knee joint, the ankle joint, and of course, generally the entire quadriceps muscle, hamstring muscle, the entire muscles of that particular lower limb. What is the intervention approach? Remember, our approach is one, the means and the method. So the means, in terms of the domain of pain, what is your means? Your means is you have heat therapy as one means of taking care of the pain, soft tissue release with topical analgesic as another means of taking care of the pain. Now, under the domain of motor function and mobility, the approach, intervention approach here, you have muscular EMS, electrical muscle stimulation, passive stretching, strengthening exercises, gait re-education, balance training, and if need be, use of orthosis. That is your intervention approach. Now, I give us another case example quickly so that we can round up. A child by name Y is a 3-year-old boy born with spinal bifida, meningomyelocele with congenital talipes equinovarus and hydrocephalus. A further assessment reveals that this child has double incontinence, patchy insensate skin from pressure or orthotic appliance. Now, can I take a moment? I want to ask us to unmute. Who can tell me how many rehabilitation domain we can identify in this case example?
Okay, please, if you have a response to the question, you can kindly unmute your mic and speak. Thank you.
Let's not waste time on it. Quickly, please, if you want to say something, I need to be sure we're all carried along in this class and we understand. Please, how many domains can you identify in this particular case study?
I think there's neurological domains.
Bladder. No, I'm contributing now.
Okay, ma, if you don't mind, can we do it this way? Person can raise a hand and then we can unmute the person to speak.
Okay, I didn't hear that. I didn't hear you.
Okay, I say that if you don't mind, anyone with the answer to your question can raise up his or her hand. Then we can unmute the mic to
All
speak,
right.
just to
Okay.
have traffic.
Okay, do I have the authority to unmute? I thought it's the host that is doing that. Am I the host?
Yes. I will do the unmuting. I will unmute now.
Okay. I have Suleiman Aminu. I have Madam Ngozi. I have a few people that have raised their hands. Please kindly quickly speak up.
Okay, thank you very much for this lecture. The question from the case study, what I can see there, we have a combo of, there are a lot of domains involved. The first one I can identify is that of the bowel bladder. management and toileting. Then, secondly, we have for motor function and mobility.
Motor function,
Then,
mobility, yes.
yes, but for the, well, I don't know, but if the cognitive and mental function would be involved, because of the case, the pathology of that case, I think, I'm not too sure, the cognitive and mental should be assessed, but the child is still too young. Maybe as the child grows, we'll keep assessing and reassessing the cognitive and mental. Yes.
Okay. All right.
Thank you.
Thank you very much. Okay. I think I'll take us back to the domains. Thank you so much for that. In actual fact, the domains you mentioned, very correct. Very, very correct. But there are also some domains that the main condition there is spinal bifida myelomeningeal cell. So intervention for mental and cognitive function that you mentioned is very, very important. It's very important because this particular child, we said, is a 2-year-old child. This 2-year-old child should be able to communicate at the level of 2 years. But do you think this child presently can do that? No. 3-year-old boy. This boy cannot do what we've just talked about now. So the issue of cognitive and mental function is very, very important. It's a domain that needs to be taken care of in this case. So how do you do that? You refer to a cognitive behavioral therapist. Furthermore, if we go back, there are still other domains. What about the domain for skin care? If you look at the history, you find out that it's written that this child has patchy, insensitive skin that keeps having issues with orthotic device. That is also very important. That's also another case for this child. Now, this child has hydrocephalus. Because of that, vision impairment is something that needs to be dealt with in this child. So that child, you will need to refer to the ophthalmologist. Very, very important. You will need to refer to the ophthalmologist. Now, for this same child, 3-year-old, what of the intervention for education and vocation? In this case, we may not be talking about vocation. Well, what about education? Do you want to keep this child at home? Is there a need for this child to actually be rehabilitated to be in what we'll call probably a school for people with disability? Let me just use that. Excuse me. So, is it possible? Yes. So, well, I've given this presentation to one of you who actually requested that I share the slides. I'd like us to, later after this class, because the time is fast spent, so that we don't keep us too long, take time to look at this case sample and then identify the domains. Now, what about the interventions that one might use in the domains? What are the interventions? I already mentioned that of cognitive and mental function. How do you intervene? You refer to the cognitive behavioral therapy. What about the congenital talipes equinovarus? What's the intervention? Your intervention target is the ankle joint. Of course, incorporating also the knee joint. Because when you're going to actually, your intervention approach, probably you're going to make use of your, what do we call it? Our serial casting pattern. I've forgotten now, I'm trying to remember it. Serial casting that we do for CTEVs.
Ponseti.
Ponseti, thank you so much. Ponseti. So that's an intervention for that particular domain of function and mobility. So you can take time to look at this particular case example. Now, the last question there says, insert the intervention you will use to treat problems in each domain function. Insert it. I'll go to the next slide so that you can take time later to think of it. So under this particular example, look at the this one I've listed out. Intervention for cognitive and mental function is a domain. Vision impairment is another domain there. Speech, language, and communication function is a domain there. Bowel and bladder management and toileting is a domain. Intervention for skincare, intervention for motor function and mobility. So look at this. I'm now trying to put the interventions and put the intervention approach in each of them. For cognitive and mental function, you refer to the psychologist or the cognitive behavioral therapist. For vision, you refer to the ophthalmologist. Probably they will give assistive visual aid, but that is their own field. But you are intervening by referring. Speech and language communication, you refer to the speech pathologist or speech therapist. Bowel, bladder, and toileting, you refer to the toilet training clinic, specialist clinic. Skin care, you refer to the skin specialist, the dermatologist. For motor function and mobility, where do we come in? You talk about what? Talk about your Ponseti. After your correction, apart from that, remember, it's spinal bifida. So apart from the CTEV, you still have weakness in the lower limb. So you have your electrical stimulation, the functional electrical stimulation, you have muscle strengthening. These are your intervention approach as a physiotherapist, hip stability exercises, range of motion stability exercises, mobility training. If, depending on the level of the spinal bifida, at what level of the spine it is, you may have to teach wheelchair management if it's a child, if it's a level at which the child cannot achieve independence. So in conclusion, it is very vital that you understand how relevant intervention is to the patient. Remember, you are not intervening just by attending to your own area alone. When you're assessing every domain you can bring out, you intervene by either referring or attending to your own aspect. Analyze the intervention. Ask yourself, are you skilled to implement this intervention? If not, refer to the specialist. If it is not your field, be aware of alternatives outside your own expertise, according to the WHO package of intervention and rehabilitation. And then you need to decide how to treat the aspects that your chosen intervention will not treat. You need to know what to do and do what is required. Remember, the focus is you want to restore function. All right, thank you all so much for the time. I think that is all for the teaching today. Thank you.
All right, ma. Thank you so much. Wow, like the class is so practical, and I believe that each and every one of us can attest to it. Thank you so much, ma, for taking us through today's class. And I know we all have questions. So 3 persons will be allowed to ask questions because of our time. After that, we'll call it a night. So we have about 2 hands raised already. So one more, and that'll be all for the questions. So please, Mr. Sani, can we hear your question, please?
Yeah. Thank you, Ma, for the lecture. Thank you. What I want to point our attention to concerning the last case that was the description of the last case that we look into, all the intervention. Yes, the intervention. Yeah, this last case. Are we not looking at the cost effects of this management? You know, referring these affected patients this 3-year-old boy, you know, I'm looking at what about the cost effect while referring to different specialty. So I'm looking at what about when it happens that we try to reduce, you know, some of the um, referral. There are some of our physiotherapists, even physiotherapists, when we manage our patients, we act as psychotherapists and some other profession, you know, looking at the whole economical issue in our own setting of Nigeria. So I'm looking at how can we just reduce this whole referral maybe to like 2 or 3 that will be cost effective because we don't know the financial strength of this patient and also in general, you know, referring a patient with this condition to different specialties. I'm looking at the financial burden. I don't know if it can be an explanation or now can reduce the cost effect for of this management of such patients.
All right, can I answer that?
Yes, ma, you can go ahead.
Okay, thank you. Financial implication. I don't want to throw a question back to you, but I want to give you a scenario. Would you prefer, while you're trying to consider the cost implication for your patient, would you prefer to just hone this patient, manage this patient, and probably the patient is able to now achieve mobility and motor function, but this patient cannot see? All because you're trying to be careful. You know that they are managing to pay through their physiotherapy treatment sessions. So let's just save the money for physiotherapy so that they can continue physiotherapy. And you've been able to achieve some good function and motor and mobility, but this child still cannot see. That is part of what WHO is trying to avoid. That yes, you have achieved motor function and mobility, but in actual fact, this child is as disabled as any other person in the society. This child has not achieved rehabilitation. And so the child, now let me break this down. When a particular condition is not well attended to, what happens? When any system is affected, every system is connected, there is interaction. The child that can't see well, it has a way of affecting his movement and his movement pattern. When movement is affected, other functions are affected. When other functions are affected, productivity is affected. When productivity is affected, livelihood is affected. When livelihood is affected, quality of life is affected. When quality of life is affected, lifespan is also affected. Yes, as much as possible, we're talking from our own angle as Africans, or let me use the word Nigerians, because you want to be careful. If I refer this patient now, they will just do surgery and spoil this joint. They'll just scatter this joint again. What this one thing we have achieved now, we want them to just, you know, probably the child has some form of joint stiffness and muscle contracture, and you know that if they can just, if the plastic surgeon can just help do a little release, we can achieve more function. And now you're afraid, they will just spoil this hand again. Now, I beg, let's just leave it like this. The issue is you have not helped that child to achieve maximum function. Yes, we can consider the financial implication, but it should not stop us from making the child or the caregivers aware of other available interventions. Let them make the decision that because of cost implication, they are not ready to go ahead. Let them be the one to make such a decision. I don't know how many of us are familiar with issues in your clinic, in the inpatient, when a patient has just had surgery, fracture reduction, and then they are referred for physio, and the patient tells you that, I beg, when we reach us, I go to do it myself. Please, I not get money again. Now all my money I don't use for surgery now. Where which one be physiotherapy? She go to manage. We go to work out small. We go trying to tell you that they don't have money for physiotherapy. She is to teach him how to use crutches. We will find a way. And several years after, this child is returning. Why? Because the child has a leg length discrepancy or a wasted atrophy of that other leg because somebody did not allow what needs to be done to be done. So I think considering financial implication, let's still make the available offers and interventions known to the caregivers, known to the patient, and let them decide that. I don't know if that clears your question.
Okay.
Hello?
All right, Ma. I think you answered to that on the chat box. Let's get to hear the other hand raised for his question. Mr. Suleiman, please, you can unmute yourself and speak.
Yeah, good evening, Ma. Thank you very much. Good evening, moderator.
Good evening.
Yes, thank you very much. I have two questions. Number one, please, any difference between supportive and palliative rehabilitation? That's number one. Number two, with respect to the first 18 months of life, that it is the rapid sensory motor development stage. So is this still applicable to children with delayed developmental milestone? Thank you very much, Ma.
Okay, thank you very much. When you say supportive rehabilitation, I'll just use a simple word. Supportive rehabilitation does not necessarily mean you're giving rehabilitation to somebody with a terminal illness or chronic illness. You can give supportive rehabilitation to even somebody without a chronic illness. But palliative rehabilitation is the rehabilitation we actually give to those patients that are having one form of chronic illness or terminal illness or the other. So that's where the difference. But it's not entirely, it's more of a palliative care than a supportive care. You can give supportive rehabilitation to a geriatric patient, not necessarily because that geriatric patient has a chronic illness or a terminal disease. Do you understand? Do you understand, sir? Mr. Suleiman?
Yes, Ma, I'm getting you.
Okay, all right. So do you understand that? Does that answer that first question? All right, I go to your second question. The second question talking about the sensory motor, the critical period. Yes, please, it applies. It applies to even the child with delayed developmental milestone, the child with cerebral palsy. Now, the only difference here is the example of a 3-month-old baby without any form of brain injury or developmental delay. The difference between that 3-month-old baby and another 3-month-old baby with neurodevelopmental delay or development issues is the problem of information processing, the ability of the brain to process information, the speed, the ability to understand information, process it, and interpret it. So both of them are exposed to the sensory motor critical period of development. The only issue is in that child with one form of developmental delay or the other, the rate at which the brain can even process or even understand the information, sometimes in some of them, depending on the degree of brain injury, sometimes some of them, the brain cannot even process the information in the first place. So when you're talking about the critical sensory and motor development, it is almost non-existent. But through your therapy, using neuroplasticity, you're trying to engage the brain to be able to interact with his environment and be able to interpret something. But unlike the baby that does not have any form of neurological issues, that baby does not even need you. All the baby needs to do is to look at the environment, study the environment. And that sensory motor period of understanding the environment and learning takes place naturally because the brain can receive information, process information, interpret information, and translate it to a command. Then the child begins to learn it. So it exists in both of them, but it is actually how much that the brain can be able to interpret or understand that is the difference. It is still the same line of treatment we use for those with cerebral palsy. A child with cerebral palsy with the history of birth indicating and giving ideas. For example, in our neonatal unit in my hospital, we have a child that has SBA at birth, that's severe bad asphyxia at birth. You understand, already in the NNU is referred to us. We're already teaching. By the time the child is even discharged at 2 months, we're already training and teaching, handling, carrying, positioning to the mother, because you already know what is going to come up afterwards. You're already teaching it at that early stage. You're not waiting until that child will come. The mother will come at 6 months to come and tell you that the baby cannot carry neck. You're already training and teaching. Do you understand? So
yes, ma'am.
You have that information. So you're now not waiting for the 4 to 18 months critical period to allow that child allow the brain cell just remain dormant. No, you're already teaching, and the child can be able to achieve much compared to the one that has the same severe bad asphyxia and is taken home, and then at 8 months, the mother brings and tells you, this child cannot carry neck. There's a whole world of difference between both of them.
Okay.
Do you understand, Mr. Aminu?
Yes, ma. Thank you very much. So we can
All right,
capitalize on rehabilitation during that period, oh?
You said?
I said we can capitalize on that to intensify rehabilitation during that period, if that's the case.
Yes, you can. That is the whole focus. Emphasizing that critical period. You can achieve much.
Okay, thank you very much, ma.
All right, sir. So,
okay. Thank you so much, ma. I don't know
right.
if you have any other thing to say.
Okay.
Yes, ma'am. Before we can call it a night, maybe like a summary.
Thank you so much. Thank you, everyone, for being in the class.
Okay. All right. Thank you, ma. Please, can we appreciate her for tonight's teaching? Can we say thank you, ma?
Thank you, ma.
Thank
You
you.
did
Thank you
justice
very
to the
much for the lecture.
everyone.
Thank you very much. Good
Thank you
night.
so
God
much.
bless you, ma. Thank you.
Appreciate
Thank you,
you.
everyone. Thank you.
Okay, so in the absence of any other question, we'll call it a night. So thank you so much, everyone, for coming, and thank you, ma, for. Okay, I think Peter Dera has something to say. So please hold on. Let's hear before we dismiss.
Thank you so much, Mr. Victoria. I appreciate all of us for coming around for this class, and I deeply appreciate the facilitator for today's class, Dr. Deborah Kinyemi. Thank you so much. That was really interesting. So we'll be having a quiz tonight. I've been trying to retrieve it from my laptop, but since I'm having some issues, it's been hanging. So, but then expect it in like the next 5 minutes. I will send it and it will be open. The quiz is going to be open for 12 hours. So let me say by 10:30, the link for it will be withdrawn. You won't be able to write the quiz. And remember that the quiz is also an important aspect of your training. So I will really encourage us to, do the quiz immediately you see it. That's all from my end. Thank you. Okay, what I mean by 12 hours means that the link will be open for 12 hours, not that you write the quiz for 12 hours, please. Think let's get that straight. Thank you.
All right. Thank you so much, Ma. So please look forward to the quiz on our WhatsApp group. It will be sent there. Please, and do well to respond to it as soon as you see it. All right, that's it for tonight. Thank you so much, everyone, for joining. Have a wonderful night rest.